labor and delivery unit. And I made this podcast in order to show students in a maternal fetal class rotation a little bit about the tools that we use on a labor and delivery unit to kind of expose you so that when you come for your OB rotation, you're not so overwhelmed. There's a lot of specialized equipment that we have here, and to make the most of your rotation, you want to be able to be familiar with some of the tools so that you can also focus on the birth process that the patient has. It's a very beautiful and intimate and challenging job to work in labor and delivery, but it's wonderful, and I hope you have a great rotation. So enjoy the video, watch it as many times as you need to kind of familiarize yourself with the tools, and we'll go through them, and the basic goal for you is to just have a general idea of what these pieces of equipment are and why they're used. You don't have to memorize them, but that way when you're in a labor and if the physician or the midwife or the nurse is talking about something, you have a little bit of a working knowledge to draw from. The first place a woman comes when she's being evaluated for labor is a room called the triage room. So this is an example of a triage room. What you'd see here is a stretcher that could be made mobile if there was an emergency. You'll see a monitor, and we'll talk about this in a little bit, but this is where we watch the fetal heart tracing and the contractions. So one of the tools that we keep in the triage room is something called a Doppler. And this machine is to measure or to monitor fetal heart tones. And you would put a little bit of lubricating jelly on this, and you would turn it on, and then you would place it on the lower abdomen, and you can pick up fetal heart tones. This is especially good if someone's in their first or second trimester, or also if they're in the birth suite and they're having a low intervention birth. So we have this Doppler to measure fetal heart tones. This is an ultrasound machine. Many of you are familiar with this, but we keep one of these up here in the triage room, and we move it from room to room as needed. And this is to assess where the fetal head is. So you want to make sure that the baby is head down if you're anticipating a vaginal delivery. So a lot of times the doctors will quickly assess this at the bedside of the patient. Another thing we measure on a woman to assess how far in labor she is her cervical dilation. And you've read a little bit about this in your text. But basically this is a good visual reference for you. The cervix on a woman would start out at 0 centimeters. So here you can see 1 centimeter, which is basically a fingertip. You can get 2 centimeters, 3, 4, 5, and on up to 10. And when they're 10, they're considered complete. So this is assessed by a sterile vaginal exam that you do with your hands. You put a little lubrication on top of your sterile gloves, and the practitioner would go in and assess how far dilated they are. And typically, if someone is greater than 4 centimeters, they'll be admitted for labor. When a patient is admitted for labor, you're going to start just like you would with any normal patient. You're going to do an assessment. That would start with vital signs. You've got a blood pressure cuff, which you can change for size. It's an important tool. You can measure pulse oximetry. You guys all know about that. Thermometer. So after you've completed your vitals, you're going to do what's called monitoring the fetal heart tone and the contractions. And you can see here as an example of a contraction pattern. You can see the contractions here on the bottom, little mountains, and you can see the fetal heart tracing. And you may wonder, how do we pick this up and how does it get on this computer screen? So there's two very important tools that you'll see that will be in every labor and delivery unit. You'll have something called a TOCO transducer, and this is what measures the contractions, and it measures the frequency and the time, how long they last, but it doesn't really tell you how strong they are. We'll talk about a tool that does that later. But it's really important to just know how often they're having them. Are they having a break in between? Are they in a regular pattern, etc.? So the TOCO transducer, commonly called the TOCO, is connected to the monitor here, and the patient will be positioned in the bed. They've got these little straps here so that you can attach them onto their gravid abdomen, and you will place this on top of the uterus, and you can feel between the abdomen and the uterus where the uterus starts. It's usually a hard muscular feeling, especially with a contraction. You'll place this on here and attach it. So this is the TOCO transducer, also called the TOCO. Then what you'll place to get the fetal heart tracing is a fetal heart monitor. And what you'll do is you'll put a little bit of that lubrication jelly, the same thing we use for the Doppler. You'll put that on here, and then you'll kind of palpate the abdomen with Leopold's maneuvers to assess where the fetal lie is, because you want to see where's a good place on the back so that I can pick up the heartbeat. So you've done that on the patient that's in the bed, and you will find the baby's heartbeat. Okay, and that's below where they place the toco. And then you'll attach that on. And so that's how you get this reading. And patients that are hooked up to any kind of drugs or just in assessment for labor are going to have a toco and a fetal heart monitor. So now I'm going to talk about 3 specialized tools that you would only see on a labor and delivery unit and some of the reasons that we would use them. We talked a little bit about the toco transducer and the fetal heart monitor to measure for contractions and for the fetal heart rate. Well, sometimes you may have a problem picking those up, and you may need a different tool to help do that job, because it's very important to know how strong the contractions are and how is your baby doing, because your fetal heart rate is what's giving you the idea of whether your baby's doing well or not, if it's tolerating labor. So we talked a little bit about cervical dilation, and that's important to remember, because in order to use these tools, you have to have your cervix has to be a little bit open. So the first tool I'm going to talk about is something called an amnio hook. And this is what's used to artificially rupture membranes. So inside the cervix, you've got the amniotic sac with the fluid around the baby. The practitioner, if the patient is dilated and they want to speed labor up, or they may have another indication for using this, the patient has to probably be at least 2 centimeters or greater. They'll do a vaginal exam, find the cervix, and then they will, and this is only done by a doctor or midwife, they'll go in with the amnio hook and rupture the fluids. Okay, so this is an amnio hook. That's one tool you may see commonly used. Another tool is called a fetal scalp electrode. So this is used when the fetal heart monitor, the external monitor, is not picking up the fetal heart rate tracing very well, or you're not sure if you're getting maternal or fetal. And that's an important distinction to know, because the heart rate for a fetus would be between 120 and 160, and the heart rate for an adult, you'll remember, is less than 100. So they're very different. So if your baby's heart rate is less than 100, that may mean you have a problem, and you want to make sure that you're picking up the right heart rate. So the fetal scalp electrode is used for that. So to insert the fetal scalp electrode, the practitioner is going to be in a sterile fashion. They'll have sterile gloves on, and they will do a vaginal exam, so they will know how far dilated the patient is, and they'll have their hand in there, and then they will slide this tool, and see that little tiny metal electrode right there? They're going to slide this in and make contact with a hard spot on the fetus head, and then they're going to twist it clockwise, 2 rotations, until it's 2 millimeters into the fetal scalp. And then there's a way to take all this off. So basically this plastic tubing comes off, and then you're going to connect this to the monitor so that it will show up on your screen. And as soon as you plug it in, you should be able to hear the fetal heart rate. So this is called internal fetal monitoring with a fetal scalp electrode. Another internal monitoring tool is an IUPC, which stands for an intrauterine pressure catheter. And this is going to be an internal tool to measure contractions. So remember how I said when you saw them externally on that monitor, you can see the frequency and you can see the duration, but you don't know the exact measurement. Well, there might be some cases where you want to know if your patient's contractions are adequate. Say she's not dilating very quickly, or she's not dilating at all, and you want to know, yeah, I see these contractions hurt, but are they strong enough to actually make the cervix change? Because the contractions are what cause cervical dilation. So you may need to put in an IUPC, because once you put this in, it will tell you in Montevideo units, or MVU, the actual measurement, which is the tool providers can use to assess for adequate labor. So again, just like with a fetal scalp electrode, the provider is going to use a sterile fashion. They're going to do a cervical exam, and the patient has to be ruptured, and they have to be at least 2 centimeters dilated. They're going to put this in, and then they're going to slide it up against the fetal head between the uterus and the head of the baby. So this isn't actually attaching to the head. It's sitting right up against the uterus so that it can measure the contractions, because the uterus is a muscle. So every time it has a contraction, it's kind of going to be pressing down on this pressure catheter, and you're going to get a reading. And you want your MVU units to be between 150 and 300. You all are familiar with an IV pump. They may look different at different facilities, but this is a basic dual chamber IV pump. because your labor patient may need to be getting fluids. The common fluid for infusion on a labor unit would be something called lactated ringers, or LR. So they may have a line of that going. They may be an induction, so they may have a line of Pitocin going in another line. And another thing you might see is something called an epidural pump. So one of the options that patients have for pain control is an epidural, and it's a catheter that goes into the spine, and there's going to be a medicine that would be running through here. In our case, it would be ropivacaine. So you might see this pump, your nurse programming this to make sure that they're getting the correct epidural dose. So when delivery is imminent, you're going to see something called a delivery table that will be taken into the patient's room. And because this is just a general overview, I'm not expecting you to remember what each of these tools are. I just want to expose you to the amount that you might see. But on a general delivery table, you may see a sterile gown for the physician or the midwife. You'll see sterile gloves that we've talked about multiple times. They'll have a fresh pair for the delivery. You'll see a variety of different rags for bleeding and cleaning. This is called a placenta basin. So after the baby's delivered, then we wait for the placenta. And the placenta would go in here because we always assess that. And this is an under buttocks chucks pad just to kind of prevent the mess that ensues with labor. Here's a bulb syringe. When the baby comes out, the head will come out, the provider will suction out the nose and the mouth. And then once the baby delivers, they let the cord pulsate for a few minutes, and then they're going to clamp and cut the cord, the umbilical cord, and then what they'll do is they'll collect cord blood, and they'll put it in here, and that'll get sent down to the lab. And then they'll have a cord clamp here, and they'll usually offer to let the father or whoever cut the cord. So this is just some of the common items that you'd see on a labor and delivery table. After a baby is born, we usually try to put it skin to skin on the mother's chest. Sometimes there's problems and we need to assess the baby a little bit sooner, or the mom wants us to just check the baby out. She's had enough time, so we bring the baby over to a warmer. Either way, this is the tool that you're going to see. And there's a couple pieces of equipment that you'd see on any warmer. First of all, you got a stethoscope, and as you can see here, it's little compared to this one. It's a baby stethoscope, so you can listen to the heart and the lung sounds with that. We've got oxygen here that's programmed into the warmer if we need to give the baby blow-by or pressure. We've got a tool called for suction here, and we can put this in through the nose or the mouth to suction out the stomach if the baby has meconium when it's born. This tool is called a laryngoscope, and the pediatrician or the nurse would use this to go into the baby's mouth. If the baby was a mech delivery and needed to be intubated, you'll see one of these sitting out on all delivery carts. There's a large one and a small one with the warmer, depending on the size of the baby. If it's preterm, they'd use a small one. If it's normal term gestation, 40 weeks or greater, they'd use this. And they would go down in here and check for the vocal cords, and then they could place an ET tube if necessary, and an ET tube looks like this. So all of these warmers are stocked with various supplies like that. And then some basic things that they all have is a little hat, because babies can lose heat. There's heat that's coming off of this to keep the baby warm. We'll measure the head circumference and the length, diaper, temperature. So here's where the baby would be to stabilize. A nice option for our low-risk birth candidates is something called a birthing suite. And as you can see in this room, we've got a nice double bed that we put lots of coverage on for the labor and delivery process. And there's a tub over here that you can use to labor in. And you can even do a tub delivery if you want. And then there's also some other tools that you may see some patients using to help with natural labor especially. One of them is this thing called the birthing ball, and the patient can sit on the ball kind of to help relieve some pressure. And another good thing about using the ball is that it allows the baby to take advantage of gravity and kind of come down in the pelvis. People can roll around with their contractions, so the ball's a popular thing. Something else you could see is this item called the birthing stool. and the patient can actually deliver on the stool. So what that would look like is we'd spread out some linens on the floor, and the patient could be sitting like this, and they usually have their support person behind them, and they're able to use these handles here to kind of, when they're pushing, they can kind of pull down and push through their perineal floor. So this is a popular option as well. For some women, it really helps to have a visual connection to the baby coming out, and so we can use this mirror here, and we can wheel it into either a birth suite or a regular labor and delivery room, and that way the patient can actually see the progress they're making when they're pushing, because sometimes the pushing stage can go on for what seems like a long time for the patient, and this way they can actually see the baby kind of coming down and the crowning, and it can be a beautiful experience. So the mirror, the tub, the birthing stool, and the ball are all non-traditional methods that are used to kind of help with the natural labor process. I hope you've enjoyed this module, and I hope you thoroughly enjoy your OB rotation. Like I said earlier, it's one of the most special experiences that you can participate in, and it's a very important time in a patient's life. So enjoy the information and enjoy your rotation. Thank you.